Hello, I'm Donal McCauley, and welcome to this BMJ Leader Conversation, where we talk to the key opinion leaders in health and medicine around the world. Today we're in South Africa, and I'm talking to Shrikant Peters. Shri, you've a very interesting background, but let's go to the very start. What got you interested in medicine?
Thanks, Donald. You get to the end of your schooling career and you're good at some subjects, you're bad at others, and you try and engage for yourself where you would like to be. For some people, it's following what their parents would like them to be, and for others, it's, what do you have an innate passion for? I think, like many medical students, the question I wanted to ask myself was, in what professional space, in something that would use my abilities in sciences and biology, as well as my empathic side to help people. And in finding medicine that way, there wasn't really anything that could come close to the combination of science and the humanities, and the utility with which you could get out of a medical degree. So yeah, that's how I came to medicine. And then we had a long and winding approach to get into public health and management.
Now, let me bring you back to medical school because I've been very privileged to visit South Africa and indeed your University of Cape Town. So tell me a little bit about the medical school and how the communities, is there integration, is there discrimination? What's the current situation?
And I must say, I speak as someone under the age of 40, but feeling quite old because of the rapid changes in financial flows and cultural psyche of students and practitioners in our country. I came of age, just around, well, I turned 7 when we had our first democratic elections, which meant I was really the last group of kids that could remember becoming a democracy. I finished my undergraduate medical school time in 2010. And at that stage, the question we had in our minds is where we would be sent for internship and community service. It was just after the financial crisis of 2008, and we were yet to feel those effects fully. Since then, the economy of the country has been a bit listless. And we failed to grow as much as we had in the first 15 years of our democracy. And for that reason, we have less money to throw behind the education and health departments. And now I'm about 14 years out of medical school. The questions confronting our young doctors is not where I will get placed, it's whether I will get a post. And that is something we're seeing replicated for interns, for registrars, and consultants. We have 300 people applying for one post. We've got a heavily constrained budgeted system, and it's quite difficult. And in that competition for spaces and for career progression opportunities, the noise does get quite loud. That being said, in 2008, when I was still an undergraduate, I made the conscious decision to stay and be a South African medical doctor because I felt that there was nothing else of higher regard in my professional undergraduate brain. Had the opportunity to travel to the States if I wanted to, but I wanted to be a South African doctor. We have an ideology in this country that focuses on a preferential option for the poor, for decentralized care, for the primary healthcare approach, and for district health systems. And that comes through quite strongly in our undergraduate curricula. And I'm sure it's one of those driving hidden aspects of the curriculum that drove me towards public health. The idea that, medical care was not simply about biomedicine and technical accuracy. It was about providing the most utility for the most number of people and using the budgets we do have efficiently. And I do feel that South African doctors are equipped to take a history, to examine, diagnose, and manage, sometimes in the most constrained of circumstances without access to any fancy modalities, or sometimes, unfortunately, ICU or high care beds even. And we're aspirational in that we'd love to head towards a national health system of our own, but very aware of the constraints that such a system brings to beds, to access to care, to waiting times. So it's an interesting space to be in. South Africa has never been an easy place to be in. We have a quadruple burden of disease that all of our junior doctors and seniors manage on a daily basis. And we've been through quite a bit the last 15 years with a fracturing of our political space between left and right, similar to the rest of the world, from what I can tell. But in the most recent elections, and the way forward does seem to be coalition building and consensus building. And we're hoping to bring together those warring factions of the political ends as well as the clinical, medical, and public health spaces to have a functional system at the end of the day for our patients and doctors.
I'd like to come back to that in a moment or two, but let's just move briefly back to your education, because after you did your medical degree, you did an arts degree.
Yes. So I had done my medical degree, and throughout my medical degree, they slowly peel open the clinical spaces to medical students. And so we would start, our first introduction to clinical spaces was obviously percussing and palpating in the mock wards. But very early on in our careers, we were able to go out onto the mobile clinics. We run the largest student-run free clinic in South Africa called Shoko. And those medical students go buses into the communities to assess patients, present to doctors, and see for themselves how care is delivered in communities. And for me, that really showed me the importance of people working on the back end of the healthcare system. People that would make sure that buses had petrols, that pharmacies had drugs, that locum doctors were available for their shift. Because in as much as we are training classes of 200 doctors at a time to go and deliver care, if we insert them into dysfunctional systems, we have burnt out doctors and patients with the outcomes that we didn't want them to have in the first place. And so this concept of needing a functional system was very, very relevant from an early time in medical school for me. Whereas some places do allow doctors to go straight into specialty programs after their degrees, we have at least 3 years of clinical practice time where you do your 2 years of internship and you rotate in everything from anesthesia, orthopedics, family medicine, obstetrics and gynae medicine, surgery over a 2-year period. And then you do another year of community service, generally in a smaller facility, a lot more responsibilities, managing your own ward or emergency center, sometimes doing a Caesar and an anesthetic together on one single patient by yourself at a time. And so you're kind of locked in where you can't really specialize. And you have the ability, if you've been a medical student, you know that you're a full-time student and a full-time worker in that final year. And so I didn't want to lose that opportunity. And being public health and systems minded, I wanted to know more about politics. I wanted to know more about economics, and that's stood me in good stead for the current space we find ourselves in. And I wanted to understand philosophy, especially the philosophy of science. You know, the fact that when we take a history and we diagnose, as scientists, we're actually coming up with a hypothesis and testing that hypothesis. And so it was very, very interesting for me to be able to be a junior doctor, seeing patients on the wards, and then being a humanities student post-call, going to write my examinations, sometimes on ARVs after a post-exposure prophylaxis, which was a head trip. But it was a very interesting experience.
Well, part of your education, you also went to America. You went to Yale. Tell us about that.
So I did go to Yale. I was on a remote program. I'd also been to LA and Chicago and New York. But the Yale program was the Advanced Health Management program, which was mostly taught remotely and led here by a group called the Foundation for Professional Development, which is part of our South African Medical Association. I was in the inaugural class as an intern. And it was really an opportunity for an intern who had absolutely no hard power to assess a system as they would a patient. We're used to being painted into a clinical corner where we're told, okay, this is your degree. These are the patients you can see. You see them. We will sort everything else out. And if something goes wrong or if the system fails, this is what you tell the family and this is how you apologize and say, I did as much as I could. The problems that a lot of junior doctors face is that they can see problems in the system that are impacting patient care, and they're apologizing for them, but they have no power to change them. And this concept that the health management program took us through was hard power and soft power. And it took us through the concepts of management and leadership and project management. And so I used the Yale program to conceptualize a triage program in our emergency centers in the small hospital I was working at, because we simply didn't triage. It wasn't done, and it's still not necessarily done in a standardized way across the country. Here you had patients coming into a facility without a standardized operating procedure on how to manage the flow through the unit, how to track them into high acuity, low acuity, and how to deliver efficient care to those that needed it. It wasn't a question of resources. We had the resources, but it was whether we were using them most efficiently to get the best outcome for the most number of people. And so using that Yale program, we put in place a manual triage system in that casualty, and we monitored. We did PDCA cycles, test, retest, to see how long it was taking us to get to red and orange and yellow patients. And we've done similar things, in casualty, in the theaters, and we're looking to apply similar methodologies to the rest of this big hospital that I'm currently in now.
Now, before we move on to the public health, I'd like to bring it back to talk about the community, because you also did some work in general practice. And one of the things that I'm really interested in is primary care within the community, and primary care particularly, for example, within the townships. How does that work?
Quite difficult. So for a year, I was, after my community service and before I started my full public health time, I was allocated to the Johannesburg metro clinics. Now, Johannesburg is a massive city, and those metro clinics are far-flung. On each day of the week, I could be 100 kilometers apart. Some days in an inner city metro clinic, in the ARV division, looking at renal functions, having access to a working laboratory. Other days in a casualty in the middle of town where most of our patients were foreigners who had come straight across the border looking for healthcare, some of them in active labor on a daily basis. And then other days I would be out on the far-flung reaches of Gauteng, which would be classed as rural, where we didn't even have, we were actually operating out of container clinics, and where we had less resources than the undergraduate students at UCT would have on their mobile clinics. You had to make do with dipsticks, a little fridge and a pharmacy, and understanding acuity and understanding how to treat the undifferentiated patient, and treat them appropriately and stream them appropriately was very important. And those 3 years of supervised junior practice really came in handy. Sometimes you would have to take kiddies in your car at the end of a clinic and rush them through to a casualty if you were worried, because ambulances don't necessarily go into townships, and the distances are quite far, and the system is fundamentally broken in certain aspects. And junior doctors do make up for that. So it was very interesting because we're aspirational around primary healthcare, around a district health approach, but the numbers just don't add up on the floor. And it's very good for a junior doctor to see that and see where they can be inserted into that dysfunction to make a maximum return on investment for the country. But we need to start getting smarter in how we upskill and network our professionals in rural areas, to be able to be supported and provide a better care for our patients. And that's becoming all the more relevant now with modalities like telemedicine and other outreach services.
Well, we better bring it back to public health because that's your current career. So tell me about your career progression and what you're doing now.
So after 4 years in clinical, including some time in the metro primary care clinics, and in locum practices around Johannesburg and back in Cape Town, I had started the Masters of Public Health at my old undergraduate university. Now that program, it gives you a wide theoretical base. Some of the things that you disliked in medical school, including epidemiology and biostatistics, the things that wafted over your heads while you thought about getting back into the wards and being on call. And to be fair, the classes, when you're simply theoretical, can be quite dense, and you sometimes do fail to see the relevance to your practice as someone who is paid to see sick people and bring them back to health. But after that year, after my first year in the MPH program, I applied to the public health residency training program. Now, this meant that I joined a rotation of doctors who were all specializing in public health medicine as a medical specialty. We were being paid not to treat sick people anymore, but to reimagine the service as it should be, including everything from non-communicable to infectious diseases, occupational to environmental health, health economics, policy and development, and looking at health organization and management and systems design. And it was fascinating because the first day, my project was to look at medical referral systems in the metro that I had worked in Cape Town as a student. And the medical consultants to whom we were now seconded asked my public health consultant, yes, I'm very interested in medical referrals and I want to improve the efficiency of the system. And this is my lifeblood. I'm a clinician. This is what I do. But why do you care as someone in public health? And what are you paid to do, quite frankly? And my consultant on that first day, he thought to himself and he smiled and then he said, I get paid to think about the problems that we have. And there's some public health competencies that I think are so important that they shouldn't be limited to the specialty of public health. And they're things we should be teaching to our undergraduates. And that's how to diagnose and manage systems in the way that we are taught to diagnose and manage patients. And it's that big frustration of clinicians, as well as myself as a manager, when we don't onboard our clinicians into these problem-solving spaces because they are inherently able to diagnose and manage and plan. And that's why you see clinicians getting into policy spaces, talking about global surgery, talking about global health, speaking at the WHO, having this impact because it's medicine. But Virchow said politics is medicine writ large. And so that's the space that I found myself in. I didn't see myself in politics with a big P. I want to be focused on health. And that's where public health has taken me. Rotations in quality of care, in healthcare data management, in district health services in metro and rural, and then finally back to facility management, which was one of the last rotations I did as a public health registrar. It really was a privilege to come back to my old tertiary hospital, which I never thought I would end up in, as a trainee manager, as a public health registrar, to be able to manage and work with and coordinate clinical heads of department whilst being very junior in my career, still being a trainee, but still applying the same principles of good quality medicine and utility of care to consensus build, take us through the pandemic, escalate our ICUs, de-escalate our theatre services, and coming out of the pandemic with a team of specialists and subspecialists around me, putting together a surgical recovery project where we put on 4,000 extra procedures over a period of a year. And that was skills that I learned that I could not get anywhere else because I was a public health medical doctor on rotation, being taught how to manage and lead and be vulnerable in the spaces together with clinical heads of department at the top of their game. It really was a privilege.
I also hear that you can work miracles because you've done something really quite remarkable. You've made a 1,500 waiting list disappear.
Yes, that is interesting. It is interesting. How long is a piece of string sometimes? When we started the surgical recovery project at the end of COVID, people were asking us, how many theatre slates did you lose in the pandemic? How many patients didn't get their procedures? And we had said to them, look, based on our previous volumes, we should have done an extra 20,000 procedures that we've lost over the last 2 years. And they said, okay, we want to help you. We're donors. We've got the money. We'd like to go 50-50 with you and the province. And they said, show us your waiting lists. And we said, okay, this is what we've got. They add up to 6,000. And they asked us, where are the 20,000? And the problem with the healthcare system, obviously, if the need doesn't get met, we know that patients die on waiting lists, right? And people eventually go to incurable disease. So being on a waiting list today doesn't mean you're going to be on the waiting list tomorrow and still a candidate for surgery or even alive the next day. And so it's really for us to advocate for our patients. We could have done more. I wish we did do more surgical procedures, but that wasn't possible. We maximized what we could do. And I know for those 1,500, the 4,000 over the full time frame, we made a difference in their lives and the lives of their families. We brought them back to economic ability to feed themselves and clothe themselves. And that's something that's fundamentally important in clinical care, the fact that we can boost the economy of a country. We're always thought of as a drain on the economy as the healthcare system, but it's a fundamental capability, health, towards development and the Human Development Index as well.
Now, Shri, I'd like to finish up by asking you about something very personal, and that is about your mother. Perhaps you could tell us that story.
In the middle of that pandemic, between escalating ICU services and escalating surgical services, my mother came back from Australia. She came back to South Africa because after 6 months of lockdown, she had a recurrence in her cancer. For me, she was the archetypal clinician who we all want to be and burn out eventually as. She was a 75-year-old family physician doing clinical shifts till 10 o'clock at night, at age 75 still. And her cancer recurred. And it made me remember that we're doctors until we're patients. We got her back to South Africa after 6 months, and she was given a 10-year prognosis by her oncologist. In the chaos of the pandemic, I took her around to two different private hospitals. We were shunted post to post simply because there were no beds available, and the referral system, which I had worked on previously, was upended by COVID, and nobody was able to tell us where there were beds. She was crying on my shoulder in casualty because people had turfed her out of the ward. And it's very difficult to hear. In the end, we got her into a surgical procedure that she needed on an elective basis, a minor procedure. I remember the day because I was post-call when the surgeon called me to say, she's got a post-operative hemothorax, and she's on adrenaline, she's in ICU. And it just made me realize it's very easy in private to add a case to your list. You get paid money for this, and a bill was sent our way, but you don't necessarily get the outcome that you want. And in the private sector in South Africa, we don't have academic spaces, and I would love to see that develop and help that process develop. But it rounds out my learning and my understanding. My mother stood there with me when I graduated medical school, and she was very proud. My final lesson from my mother was when I walked into that ICU and I saw doctors doing CPR on her, and I told them to please stop. There was nothing else to be accomplished. And the fact that value-based care is so important to understand and to live and to thread through our systems, because it wasn't simply about doing a procedure, about receiving income for a procedure. It was about understanding, for us as a country, what is the volume of services that we can deliver, at what cost, and what quality of outcomes are we getting? You know, for those first 1,500 procedures that we had done for the surgical recovery project, we had a balancing measure. We looked at readmission, we looked at 30-day mortality rate, to make sure that the people that we were pushing through was not sardines through a factory. It was patients with lived experiences, with prognoses, some of them with chronic diseases that still needed to be managed after a procedure. And so, forced into this holistic understanding and concept of medicine and public health and health systems thinking, I've learned a lot. It's not easy. It hits home very, very closely. I've got a stack of adverse incidents on my desk at any one time of the day. The ability to see things from a clinician's point of view, take them through a complaints process with what we call a just culture approach to making sure that patients and their families are treated with dignity and respect at the end of the day, is important. And I've grown as a manager and as a clinician and as a person because of my personal and professional experiences. It's not easy, but it encourages us to be vulnerable and to accept our vulnerability and to lead through that vulnerability as managers and as doctors. And I do have a lot of faith in the junior doctors that are coming through because they understand that they're not superhuman. And so I think we do have a holistic group of doctors that are being graduated. I don't think that the systems they're working in are conducive to health for themselves or their patients. I think we can do a lot better with what we have. And I think we need to grow both ourselves, the current generation, the seniors, and then the juniors, the millennials, the Gen Zs, the alphas, people that are highly connected and unwilling to accept the system for how it is. We need to teach them what models to use, what thinking frameworks to use, how to apply the clinical method to improving problems in the system, in the public and the private sector, for how we generate utility and dignity and respect. And I say that as a clinician and as a bereaved family member of someone who should have had that too.
Shri, thank you very much for sharing so much of your life, your education, your career, and of course, your very personal experience. Thank you very much indeed.
Thank you kindly, Donald.